Hello and welcome to JAMA Network Open Conversations. I'm Dr. Angel Desai, Associate Editor for JAMA Network Open. Today we are speaking with Dr. Emily Sterbis and Dr. Premal Trivedi about inferior vena cava filter retrieval rates associated with passive and active surveillance strategies adopted by implanting physicians. Welcome.
Thanks for having us.
Happy to be here.
To start, can I have you both please introduce yourselves?
My name is Emily Sterbis. I'm a current radiology resident. I'm one of the integrated IR diagnostic radiology residents at the University of Colorado Hospital, and I was the first author on this paper.
And I'm Premal Trivedi. I'm an interventional radiologist at the University of Colorado, where I do health services research, and I'm the interim division director for vascular interventional radiology.
Can we start by talking a little bit about the background of the study and what prompted your interest in this topic?
Yeah, so filters have been around for a while to stop clots from traveling primarily from the legs into the heart. And for a while, there have been filters that have been placed that were really just left in with the thought that if they caused any issues in the future, they could be taken out. However, we've seen that as more filters stayed in for longer, there were more complications. And a lot of the national retrieval rates are actually very, very low with these filters. Some estimates say somewhere between 14 to 24% in the general population. It's even lower, more like 12 to 18% in the Medicare population. So our study was really looking at our experience with our filter retrieval methods and how we've changed things really in 2016 and how that affected our filter retrieval rates.
Those are pretty low rates that you mentioned there. What are some of the issues with leaving a filter in too long or past its indicated time frame? You mentioned a few complications.
Once you get past around 30 days, they estimate that the rates of complications from having those filters in place really go up. Things that you worry about are increased risk of clots in the legs in the future. Sometimes these filters can fracture, which means that if we try to take them out, you leave metallic objects in place. There's risk of the filters migrating, either going further up in the inferior vena cava than you want them to, potentially going to the heart or the lungs at times. And those rates go up the longer the filters are left in.
Now, what did you do in this pre-post study?
So we had a follow-up program in place since around 2011. At the time, it was a nurse coordinator who was helping to maintain our filter database, and from there, occasionally sending patients letters. And in 2016, we decided to take a more active approach to how we followed up these filters and how we encourage patients to get them out. And so we primarily looked at 2011 and 2016 filter rates, how were those, and then from 2016 to 2019, when we started doing our analysis, how did they improve?
Were all of the filters placed by interventional radiology specifically, or were there other service lines involved in this study?
This was specifically our interventional radiology database, since we had a little bit more control in how we collected which patients were included in the database.
Great. And what did you find?
So we found that when there was a more active approach from our team, that the filter retrieval rates actually went up. So the annual retrieval rate in our more passive method, which was sending patients letters saying, hey, you have this filter in place, it was placed for this reason, but they should really be removed if you don't need them anymore. That filter retrieval rate was 48.7%. And then when we switched to a more active model where we are more communicating with the physicians taking care of these patients after they left the hospital and communicating with them to determine, has the clot gone away? Are they back on anticoagulation now and this filter can come out? With that more active method, it went to 61.3%. With the filter retrieval rates of those filters that were placed and then had them removed within 1 year, went from 46.4% to 58.1%.
Dr. Trivedi, I'm just wondering, were there any findings in the paper that were surprising to you or things that you didn't expect?
It's a good question. We had some preconceptions, certainly some hypotheses going in, which is that generally speaking, the active approach would yield better retrieval rates. There were a couple of unexpected findings. One is that the retrieval rates increased almost immediately, so there was really no lag time, and it was pretty consistent year after year. It's rare that you see within a pretty complex healthcare system one intervention yielding a consistent signal, and that's what we saw here, is that there was a approximately 15% or so jump in retrieval rates, and it didn't really die down over time. The other unexpected finding is we thought that with the active approach, we would have a decreased proportion of patients who were lost to follow-up. That was in fact not the case. What we found is that a smaller proportion of patients were deemed requiring permanent filtration. And this is adjusting for underlying patient mix. The more active approach was associated with a greater proportion of filters retrieved. And by contrast, the passive approach was associated with more non-retrieval. And the difference is primarily driven by a much larger proportion of the patients being deemed needing permanent filtration.
Based on some of these findings, what advice would you give to patients or maybe ordering providers on filter retrieval?
Yeah, that's a great question. So I want to reflect a little bit on why this finding may be driving the difference in retrieval rate. So why is it that we are considering more filters permanent? And it also has to do with our decision to enact a more active surveillance program. So if you go back in time and look at the FDA advisories that came out at the time when we began to understand that filters are in fact associated with a lot of complications, really the gist of the message is we should be thoughtful when we place these devices in patients. We should have long-term follow-up and retrieve them when feasible. And really the implication is that the physicians, care providers who are responsible for the ongoing care of that patient should be following up these devices and adjudicating whether the device should come out or not. The problem that we have seen practically with that approach is that often the physician who requests the IVC filter replace is separate from, of course, the implanting physician, is separate from the doctors who are doing long-term care follow-up. So there's a structural fragmentation in the follow-up of patients who have these devices, and that leads to issues with the approach where the primary responsibility, if it falls on the physicians who are providing primary care for that patient, they may not be positioned well to have all the necessary information to make an educated decision on filter retrieval. By contrast, implanting physicians, interventional radiologists, we're very aware of the complications associated with these devices. We take care of them, and we're highly invested in ensuring that the devices come out in a timely fashion. And it's really just about facilitating through the framework of a surveillance program, gathering information that is necessary to make the decision for whether the filter should come out or not. So the two reflections I have is that, number one, I think to the extent that having a surveillance program at all is helpful, any passive approach or really any active approach is significantly better than no program at all. And then if it's possible logistically for the implanting physician team to manage an active role in device follow-up and retrieval, that is likely to yield higher retrieval rates in a timely fashion.
Makes a lot of sense. Based off of this, what do you think are some of the next important or potentially unanswered questions in the area that maybe you are conducting in the future?
I'm glad you asked. We actually have grant funding now to look at what I think is one of the central hurdles remaining when you look at the national problem of unretrieved or forgotten filters. There are facilities of varying resource across the United States. If you look at the gap between the aggregate retrieval rates and really any facility that has published their experience with filter retrieval, you'll see a big gap. And I think that's reflective of the fact that you have a little bit of a selection bias when facilities publish their experience. In reality, committing more resources to follow filters in patients over time can be difficult. And so we're looking for really pragmatic solutions that can be adopted at facilities of varying resource. What can work at a safety net hospital? What can work at a tertiary coronary care academic center? Those solutions are likely a little bit different, but there's probably common denominators. And that's what our investigation currently is focused on, is identifying through mixed methods research what are the common denominators to build a pragmatic intervention to improve timely retrieval rates.
A lot of really important implications for patients, for sure. Do either of you have any final thoughts regarding the study?
There's been other studies previously that have looked at other retrieval rates. And like Dr. Trivedi mentioned, just putting something in place that's realistic for an institution to really work on is, I think, really the key step. If you don't have time necessarily to set up a clinic to follow up these patients routinely, that's okay. It's okay not to have those resources and to instead do something that's a little bit more passive, so long as you have some sort of follow-up method in place to make sure that these filters just don't stay in and the patients, have no idea, oh, I have this device in that really should be coming out at some point.
I think that's a great thought to end on. Thank you so much to the both of you for speaking with me today about this important topic. This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Lisa Harden, Audrey Foreman, Mary Lynn Ferkaluk, Hannah Park, and Dr. Linda Brubaker. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. I'm Angel Desai. Thanks for listening.